講師は、現在医学教育国際協力研究センターに、客員教授として滞在されている、ジェフリー・ウォン先生に再度お願いいたしました。で、今日のテーマは、アメリカのメディカルスクールにおける、カリキュラムのリフォームということで、サウスカロライナの経験をもとに、お話し願うと結構刺激的で、非常に我々も得るところのある話だと予告では聞いておりますが、ぜひお聞きいただければと思います。
So thank you very much. Again, it's my pleasure to have the opportunity to speak to you tonight. Professor Onishi, who works in the RCME, asked me to speak about the curriculum reform and the efforts that we did at my medical school for doing this. I understand in Japan there are lots of changes that are going on and lots of changes that are being proposed. And perhaps the experience that we had may be able to shed some light or give you some ideas. I will not profess to say that this is the right way to do things necessarily, but it's one institution's story on how we got things done. And so I get to tell you a little bit about a story, and I think it will be interesting, hopefully, for you. What I would really like you to get out of tonight's talk are listed here, just to sort of become familiar with what traditional medical school curriculum and structure is in the United States. What I mean by traditional is the way that it had been from the early 1900s after the Flexnerian Revolution to essentially the early 1970s or 80s. Things have been changing pretty rapidly in the United States since that time. I listed some of the challenges, at least at our school, that we experienced to try to promote institutional change for reform. And maybe what you can do as you're listening to my presentation is to compare and contrast the different ways of our experience with the plans at the University of Tokyo or other places in Japan. What I'll do in terms of the talk today is to talk a little bit about the history of the Medical University of South Carolina, where I'm presently working, some of the traditional systems and curriculum there, and the evolution of the change that we underwent. We'll sort of talk a stepwise progression to changing the culture and also changing the curriculum there, and then some of the educational outcomes and the innovations that we developed as a result of these reforms and the changes that we made. So for those of you that don't know, this is the United States, and South Carolina is over here on the Atlantic Ocean in the eastern part of the United States. And if you use, like you were using Google Maps, and you sort of make the magnification greater, you can get down to the state of South Carolina, and Charleston is right there on the coast. If you go down even farther, you can see that Charleston is actually a peninsula that has two rivers. The people in Charleston say that the Cooper River and the Ashley River come together and form the Atlantic Ocean. That's the way they view themselves in any case. And the Medical University of South Carolina is right on that part of the peninsula. And so if we even blow it up even farther, you can see that the peninsula comes down. And that's where MUSC is. And this is a view of MUSC sort of looking a little bit southeast. This is the Charleston Harbor out here. And this is actually a somewhat old picture of the medical campus, because this area right here, which looks kind of vacant and flat, now has two very large buildings built there, a biomedical engineering building and a drug discovery building as part of the research enterprise that's gone on. As far as MUSC as an institution is concerned, it was chartered by the South Carolina legislature in 1823. I know that that's pretty young compared to Japan standards, but the United States was actually gained its independence from Great Britain only in the 1780s, and so it wasn't that much longer after that occurred. It was, depending upon you read, either the 6th or the 10th medical school, somewhere in between there in the United States. In any case, it was the first one in the southern part of the United States. The opening of the school in 1824 had 7 faculty members and 30 students, and this is the first building that was part of the medical school. By 1832, which was only 8 years later, there were 109 medical students there, and the first graduating class that they had was 35 students, which is actually pretty large back in those days. By 1860, the college had 248 students that were involved in study, and it happened to be the 5th largest medical school in the United States at that time. In 1960, of course, we had the conflict in the United States that we call the Civil War, and Fort Sumter, which is actually in Charleston, was where the Civil War started. Fort Sumter was occupied by the Union troops, and the states of the Confederacy, of which South Carolina was the very first one to secede from the Union, fired on Fort Sumter in 1860 and started the Civil War. The Civil War lasted for 5 years, and this is actually a picture of what Fort Sumter looks like now. It's this little pentagon-shaped building sitting out on this rock in the middle of Charleston Harbor. After the Civil War, most all of the buildings in Charleston, including the medical school, were all destroyed. But they say by November of 1865, the war ended in April. They had already started classes back once again, and so from the period from 1860 to 1865 was the only time the medical school did not hold any classes. There's actually an interesting bit of history. In 1872, apparently there was no money for the students to pay for their schooling. And so in something that would never at all happen in this day and age, the faculty and the Board of Trustees decided that they would hold school anyway, and the students all came and studied for free. I don't think that would happen anyway these days. In 1886, we actually had a very large earthquake in that part of the country, and here's a picture of some of the buildings that were destroyed. And so toward the end of the 19th century, Charleston and everything was rebuilding. And at the turn of the century, Abraham Flexner was an educator who studied about medical education in the United States and had this famous report that many of you know about. The Flexner Report, published in 1910, talked about the Medical University of South Carolina, and he stated that the college, despite its tradition and dignity, was sorely lacking in facilities, faculty, equipment, and money, and he believed that it was unlikely that the college would survive. So actually, in response to that, Charleston as a community sort of got together, and in 1913, the South Carolina General Assembly approved state ownership of the college. In other words, the state of South Carolina assumed the ownership for a fee of $10,000. The city of Charleston itself raised about $75,000 and started building some new buildings, and things picked up from there. Fast forward to 1955, and the medical university actually built its own hospital. And that was a pretty big deal for that time, because many other institutions, in fact some of the ones that are still very famous now, don't have their own hospitals. They use, the academic medical centers use other medical hospitals associated with them. For instance, you can think of Harvard, and they have the Brigham and Women's Hospital and the Massachusetts General Hospital, and they have all of those hospitals, but Harvard does not have a medical hospital per se. In Washington University in St. Louis, they use Barnes Hospital and Jewish Hospital, but at MUSC we actually have our own university hospital. One of the other things I want to talk about is in 1980, Dr. James Edwards, who actually in South Carolina is a pretty famous person. He was actually a dentist. He was the governor of the state. He held many other administrative posts, and he served as president of MUSC. And one of his visions was that MUSC needed to grow from this small little medical school serving the South to becoming a more important national and international institution. And so that led to two very important leaders, both of whom I've worked closely with. The first is a man named Leighton McCurdy. Dr. McCurdy is a psychiatrist who was actually born in South Carolina, trained at the Medical University of South Carolina, rose through its ranks, became the chairman of psychiatry, and then left and went to the University of Pennsylvania, where he was the chairman of psychiatry there. University of Pennsylvania being a very high-powered, prestigious institution in the United States. And then he was recruited by Dr. Edwards to come be the dean of the medical school. He served from 1990 to 2000. And during that decade, he really oversaw some of Dr. Edwards' visions of increasing the medical school's stature and importance in American medical education. In 2001, Dr. McCurdy retired, and Dr. Jerry Reeves was recruited to take his place as the dean. Dr. Reeves was also an MUSC medical school graduate. Dr. Reeves is an anesthesiologist and did his training initially at the University of Alabama in Birmingham, and then went on to Duke University, where he was the chair of anesthesia and also created the Duke Heart Center, which is one of the better known clinical centers in the United States. He was recruited back to be dean and has really moved the institution forward. And Dr. Reeves is actually the one that recruited me to MUSC in July of 2004. One of the messages that he gave to me was that the medical school curriculum when I came in 2004 was not greatly different from when he went to medical school in 1962. And he thought that things had probably changed in those 40 years a little bit, and he wanted things to be improved. So we actually had an LCME site visit, I'll tell you a little about what that is, coming up 6 months after I arrived. So the short-range goal was to make sure that the LCME site visit was successful. But the long-range goal was he really wanted me to coordinate the continuum of medical education for undergraduate medical students, for graduate residents and fellows, and actually for faculty members in education, and to sort of update the medical education curriculum that I already mentioned he thought was outdated and needed to be changed. The LCME is the Liaison Committee on Medical Education, and the LCME is that body which accredits all medical schools, all allopathic medical schools in the United States and Canada. Excuse me. The LCME is comprised of secretaries of the American Medical Association and the Association of American Medical Colleges, so the AMA and the AAMC. And those two institutions together basically set all the rules and the regulations for medical schools. And I understand from what Kitamura Sensei and others have told me that Japan is in the midst of trying to develop a similar accreditation type system for their medical schools. So the LCME accreditation, the cycle, this is a really brief description of it, and I think in a couple of, this talk in a few months will also deal much more with the details of accreditation, but just briefly, if you get full accreditation in the United States, you get an 8-year sort of cycle of where they allow you to continue with what you're doing. If you don't do as well with the accreditation visit, then your cycle is shortened. The site visit itself is a 3-day event where 5 visitors, these end up being peer deans and faculty members from other member institutions in the United States and Canada, come to your school and they review all the operations of the medical school. They review the program of study, the facilities, the operations, the finances. They talk individually to groups of students and faculty members, And all of this is a pretty big deal. There are these standards that are established through the LCME called Structure and Function of a Medical School. And all of these standards are well documented. The schools are expected to meet those standards, and then there is a database that needs to be completed showing how your school complies with all those standards. And then there is this self-study that is performed by the institution that is usually done about 18 to 24 months before the site visitors come. And the purpose of the self-study is for the people in the institution to take these standards and to really look critically at what you're doing in your school to see whether or not things are falling with what you need to have done. The self-study is actually really important because that way you get to find out where all your strengths and all your weaknesses are. And from that, when I came into the job, we used the self-study to look at our curriculum. And this is the way the curriculum looked like when I came in. This is a schematic of year 1 and year 2. And our first year of medical school, we had what was called Fundamentals of Patient Care, which ran through 4 different semesters in the first 2 years, dealing with things, helping students to become physicians in terms of physical examination, clinical skills development, medical interviewing. But they also then had the normal basic science courses. Molecular basis of medicine was essentially biochemistry. Anatomical basis of medicine was embryology and gross anatomy. Histology, cell biology, neurosciences, and physiology. And then in the second year, they had microbiology, immunology, pharmacology. Mechanisms of disease was essentially pathology. And that was the way that the curriculum was structured. For the third year, we had the general clinical clerkships in surgery, medicine, psychiatry, and neurology were split. Pediatrics, obstetrics, and gynecology, and then family medicine, rural health. And then the careers in medicine track had continued. Again, this has to do with people learning about what best they should become in terms of their subspecialty choices. And then the fourth year in our medical school had 1 requirement of advanced internal medicine, 1 of advanced surgery, an externship where the medical student performs as if they were an intern, and then a bunch of elective time. The careers in medicine ended in mid-March when the students go through what is called the match, and they find out what residencies that they're selected to do. Our old grading system at MUSC may be familiar to some of you, but we had an A, B, C, D, F grading system, where the students were graded with a letter grade, just as they were oftentimes in college and medical school, and a grade point average was determined for them. And this is roughly what the percentages were. And as you know, many of our students and studies in terms of the grade point average system is based on a normal bell-shaped distribution where you have 1 standard deviation and 2 standard deviation performances, and that's how the letter grades are determined. And that's sort of how the MUSC grading system was when we first studied it. In addition, we actually tried to rank our medical students, and so at that point we had 135 students in the class, and we tried to determine the class rank, the number 1 student in the class down to the number 135th student. The clinical clerkship grades were graded on a 4.0 scale, and actually to develop the ranking we had to go out to 1/100th of a decimal point to make sure that we could differentiate the students. When I came in, I sort of saw this system, and I didn't like it very much because I wasn't sure that the system was telling me anything about my students. What made somebody that had a 3.62 grade point average that much better than someone that had a 3.61? It just didn't make any sense to me. But anyway, that's the way the school was doing it at that point. So the LCME came. They came in January of 2005, and they had the site visit, and we actually did quite well. in June of 2005, when the report finally officially came to us, we got the full 8-year accreditation, which is exactly what the short-term goal was. In between those two dates, in April of 2005, I actually created a strategic planning event for the entire College of Medicine. And what we ended up doing was we got about 70 faculty members, administrators, and medical students to all review the self-study document, and we wanted to create vision and mission statements and goals for what we should be doing on going forward. Basically working on the problems that we found in the self-study that weren't citations by the LCME, but were still things that we wanted to fix in our medical school. And so the strategic planning event was done off campus, a full-day event. All the department chairs, deans, administrators were invited. We had student representation from all 4 years of medical school, and they tended to be the leaders of the classes. And we reviewed the self-study, trying to reach some consensus on where the medical school should be going. We came up with this as our vision statement. That was the MUSC wants to be a leader in medical education and to enhance our influence nationally and internationally. And the mission statement was to prepare our students to be outstanding physicians and leaders in disciplines of their choice. So those are things going forward we were striving to do. We had 2 curricular goals. We actually had 5 goals altogether, but only 2 of them were involved with the curriculum. And so tonight's topic, we'll just talk about 2. The first was to refine, refocus, and enhance our curriculum content. And there were 3 points on that. First was to introduce and integrate appropriate clinical science content earlier. And I understand that's what's trying to happen also here in Japan. To achieve core competencies with a broad-based plan of study, and to design some flexibility into our plan of study, recognizing that one size does not fit all. That is, one medical student's experience doesn't necessarily need to be like everyone else's, but everyone will have their own desires and needs. The second curricular goal was to identify current and develop novel and effective teaching and evaluative methodologies. And there were some points under that. We wanted to produce graduates that were adept, self-directed learners and critical thinkers. We wanted to evaluate and promote students by evidence of achievement and competence rather than by merely spending time in a certain rotation or in an activity. We wanted to utilize whatever technology we had to increase the effectiveness of teaching and the evaluation of the teaching. And we wanted to utilize a variety of teaching and evaluation methodologies to accommodate different learning styles, because not everybody learns in the same fashion. So those were sort of where we were going with our strategic plan. We also had some philosophical foundations that we wanted to put forward, and they're listed here. I wanted students to think about collaborating with one another rather than competing against one another. This is a little bit of a different mindset from where they came into medical school, where they were pre-medical, very competitive in their colleges, trying to beat out their colleagues. And it was a little bit of a change in mind for them. I also wanted them to get beyond the what. And what I mean by that is that many times students are focused on what's going to be on the exam, rather than really trying to understand what concepts are supposed to be learned. And so getting beyond just the trivial facts, but really understanding the concepts behind those facts is where I wanted them to go. And I also, in those lines, I challenged our teachers to think about how do we teach and how should we be teaching? What is it that we teach? And when do we teach it? All of those things had to be on the table as we started to reform our curriculum. So, this is a little bit of a picture to change you and to give you a little bit of a break. Miura-san and Yakari-san and I went to a baseball game. This was, where was it? What part? Jingu, yeah. This was between Todai and, I forgot the other place, school. We got B. But and I understand that athletics and competition between schools here in Japan is important, and I guess even at the medical school level. Well, in college in the United States, in South Carolina, there are two big colleges that are state schools, the Clemson Tigers and the South Carolina Gamecocks. And students from both of those institutions are always very competitive with one another. And in college, you've probably heard of all of the college sports in the United States. It's a huge, huge money thing. And a lot of the competition that people have stems perhaps from that type of competition. And what I was trying to get the students to think about is that, listen, now that you're accepted here to medical school, you're all really good, you're all really smart, there's no need for you to compete anymore, and you're not a Clemson grad or a South Carolina person anymore. You are both part of the MUSC College of Medicine. And so the whole idea now is that you're not competing against these people, you need to work with them, is the message that I wanted to get to. There's another concept that maybe some of you have heard about. This is a term from German, Schadenfreude, and the definition that I've heard used for this is that you tend to, one who experiences Schadenfreude gets enjoyment out of other people's misfortune. So when you are in a sporting event and you're at Clemson and Carolina loses, you get happiness from that. Or if you're working on an examination and you score higher than somebody else, you're happy because they scored lower than you. Well, again, in medical school, that should not be the case. And so I try to encourage or discourage Schadenfreude and work with collaboration. And this is Hermione Granger, if any of you are Harry Potter fans. If you know about the stories, Hermione is like the best student at Hogwarts. She knows all of the answers, all of the time. And because she does that, she sometimes irritates her friends. And there are people in medical school who sometimes are irritated when some of their colleagues seem to know all the answers. And my message to them was, you should actually be working with these kind of people, because if they know all the answers, they can help you to know the answers as well. And so rather than becoming irritated at a very clever and smart classmate, you ought to be working with them. And so here's the message behind collaboration, is that this is an internal medicine team. And you're working in medical school, you don't know what your colleagues are going to become. But say you become an internal medicine doctor. When you graduate, the people whom your patient here needs an operation, you're going to be sending them to your colleague who is a surgeon. And you want that person to be the best person they can be. And when you're the surgeon, you're working with an anesthesiologist, and you want that person to be the best person he or she can be. And when you, as Salcedo Sensei, recently had a baby. So when you take your baby to the doctor, to the pediatrician, you want that person to be the best person that he or she can be. And if your wife or if your sister is pregnant and goes to the obstetrician gynecologist, you want that person to be as well trained as they possibly can be. And I can go on and on. You know, if you're walking down the street and one of the crazy bicycle riders here hits you and breaks your leg, you want the orthopedic surgeon to be the best person they can be. These are your colleagues. So when you are working with these people, you want them to know everything that you know, if not more. You don't want to hold information from them, but you want them to achieve as maximally as they can. This was not the mindset at MUSC when we first started. When you would have reserved readings in the library, it would be not unusual for those pages to be ripped out of the book for some people, because someone would have read it and they didn't want anyone else to read the information because they would score better than they did on the exam. Well, that's nuts. And so we tried to change the whole culture by saying, listen, when you're working in medicine, you're working as a team. You never take care of anyone by yourself. You're always working with a team of colleagues, and you want them to be as good as you, if not better. Getting beyond the what. So this is the point of not just knowing what's on the examination, but why what you're trying to learn is important. And I also challenged our teachers to say, let's just don't ask them trivia, but let's make them think. Let's make them really demonstrate knowledge and understanding. Now, when we talked about grading on a curve and the bell-shaped curve, this is the way that if you write an exam properly, so to speak, by the educational standards, you will get distribution scores that look like this. Well, it will not surprise any of you in medical education to know this is not the curve of medical school students. That's the curve of medical school students. Everyone in medical school is already really bright, right? And so when you take a whole bunch of really bright people and you give them an examination, they're going to be skewed up towards the high end. So already you can't really figure out a bell-shaped distribution. The other thing that happens is that when you get this kind of thing, how are we going to differentiate our students? Well, so I'm going to take a little bit of a break and talk about a neat book that has nothing to do with medicine, but is everything to do about education. It's written by a mathematician named Mario Livio, and it's called The Equation That Couldn't Be Solved. For any of you that are mathematicians, this is the equation. It's a pentatic equation that talks about ax to the fifth, bx to the fourth, plus cx cubed, plus dx squared, plus ex, plus f equals 0. And allegedly, and I don't know enough math to know this, but you cannot solve this by using normal mathematics. But the reason that I go on this little bit of a tangent is that one of the mathematicians, a French mathematician named Évariste Galois, I hope I pronounced that right, he wrote back in 1831 about this whole issue of dealing with really smart people and asking them questions. And he stated this: why don't the examiners pose questions to candidates other than in a twisted manner? It seems that they fear being understood by those they are interrogating. What is the origin of this deplorable habit of complicating the questions with artificial difficulties? And any of you that have taken exams that slip you up, that trick you, not because you didn't know the information, but because the way they asked the question was so complicated and so confusing, that's exactly what he's talking about here. Secondly, it was, when will the poor youngsters be given some time to reflect on the accumulation of knowledge that we give them? Students are less interested in learning than in passing their exams. Again, this was said in 1831, and I think it was totally applicable to MUSC back when we were making changes. We were writing tests that were trying to fool people. If the information is that you want to test them on is written in a way that was very clear and they answered it, in my mind, that's great. That means they knew what they're talking about. We don't need to fool them by giving them tricky tests. How are we teaching? So this is what I challenge my teachers. If you go and look and see how much average students remember when they're taught in different ways, you have this sort of pyramid, starting with the lecture, which is generally thought to be about 5%, going down to more active learning discussions where they're actually teaching other people, and when they're teaching somebody else, they'll remember about 90% of what they're teaching. So how did we at MUSC use our time to teach people? Well, it was just the inverse. We were, like most medical schools, spending almost the majority of our time giving them lectures. And lectures, while being very efficient for the teacher, is not necessarily the best way to teach people information. Actually, this is an article from the New England Journal pretty recently about a really interesting thing that they're doing at Stanford Medical School. And that is that they are totally doing away as much as they can with lecture. What they're doing is they're putting what would be normally the lectures on podcasts electronically and posting them to a website, asking the students to go and listen to those lectures ahead of time. The lecture time then, the professor comes and it's a discussion group where the professor actually talks about the content that was in the lecture and answers questions from the students. And most of the students find that it's a much better situation than having someone talk to them. about the information. Hopefully more, we don't do this yet at MUSC, but this is a really interesting concept, getting away from lecture. The other thing is, so what is it that we are teaching? How are we teaching it? What is essential information? If you sort of look at this graphic of the amount of information that's known over time, what is essential to be known is probably somewhere on this line. So there is more stuff that's actually known that would be considered essential for medical education. Another way of looking at that is on this slide. So if we look at different basic science courses, I actually took the actual subject matters off here. So some of my colleagues in the different basic sciences wouldn't get upset. But if you look at the different rates of scientific discovery within those fields, and you look at the content that could be considered immediately relevant to medicine, it's quite a bit less. And then, of course, the licensing examinations or our multiple choice examinations can only test a fraction of that. So what ends up happening in a lot of situations is when you are teaching in basic science courses and you're teaching by discipline, all of the teachers are very excited about teaching these new discoveries that are brand new to their field that everybody's jazzed about. But they don't have any bearing on whether or not the medical students are going to become good doctors. And so this is the quandary that we have in medical education with curriculum. There is a wonderful book called A Time to Learn by a guy named Kenneth Ledmer at Washington University of St. Louis, and he's very fond of saying that medical curriculum have underdeveloped excretory systems. They cannot jettison stuff out of the curriculum. There's no way of doing it. So what ends up happening is more and more and more gets added. The students just get blasted with all of this information, and they have to sort out what's important and what's not. And so I told our faculty members, we need to stop that. So, and then the last part, when do we teach it? So here's a good example. Molecular basis of medicine. This is biochemistry. Biochemistry in the old curriculum was slotted from August to December of the first year. So what did that mean to the biochemistry teachers? The biochemistry teachers said, we have to teach everything the medical students will ever need to know about biochemistry in essentially 4 months. How likely is that to happen, right? And also, isn't it crazy because you're never going to use biochemistry ever again once you get past December of your first year? No, that's nuts. You're using biochemistry every day when you take care of patients. But this is when it was taught. And it was not uncommon to hear the biochemistry professor, when talking about a pathway, telling them, taught to the students totally out of context of anything else, that you will need to remember this 2 years from now when you see a patient with X, Y, or Z. Which is a crazy way to teach, because now the student is learning it here and then several years down the road has to remember what was taught back then. That was how we were teaching it and when we were teaching it. So these are things that we tried to change, and what ends up happening is that we were basically following what we would consider an undergraduate model. This is our baccalaureate university model for teaching in the United States. In the United States, when you're in college, you have parallel courses. You take courses in English and in science and whatever else, and each of those courses do whatever they're going to do to teach you, but they don't have any regard to the other courses. That's the way our courses were working as well. They were sort of self-contained. The evaluation systems that were happening at that time sort of encouraged what's called cycle studying. That means that if you know that you have a biochemistry test on Friday, from now till Friday you study just biochemistry and you let everything else slide. And then you look up and you say, okay, next Wednesday it's an anatomy test. So now I'm going to study anatomy until next Wednesday. And you're always in this cycle of being behind. Also in undergraduate, students are picking courses from a menu of choices in order to fulfill a major. In medical school, everybody takes everything and they have to pass everything. So there is no choice. And so this 102, 103, 101, 201, 301 model doesn't really happen in medical school. If you're taking different courses in college, it will build upon one another as you follow things in every semester. But in medical school, as I just told you, like for biochemistry, you got everything in the first 4 months and nothing else was done. So these are some of the things that we tried to change, and we had 4 premises. The first was, how do we ensure that what we teach the medical school students is actually relevant? Try to combat this information overload. How do we most effectively and most efficiently use the time of the students and the faculty members? How can we best assure that learning is actually occurring? That is, to de-emphasize rote memorization and encourage problem solving. And lastly, how do we promote collaboration and instill a sense of professionalism in our learners? So the first thing we did was that we eliminated the 4.0 grading scale, and we went to a pass-fail system. Now, this has actually become pretty much the standard in United States medicine now. We actually do have an honors designation, so there are 3 gradations of students, but we tried to get away from ranking students from 1 to 135, and we incorporated holistic evaluations of their performances. So now it wasn't just based on the scores of examinations, but it was based on a whole bunch of different things, many of which have important implications on becoming a physician. We created academic and behavioral standards rather than comparisons. And so what I tell the students is that everybody here has the potential to graduate first in their class. You're not competing against anyone else. You're competing against the standard. And we created more opportunities for evaluation, including evaluation of your peers, which is difficult to do when you're having a grading point system. Here's our pass-fail system, and what we ended up deciding was somewhere around 70, which is sort of a raw score on examinations, is failing. This is not greatly different from anywhere in the United States. In Canada, this number actually tends to be more like 65, I found, but 70 is the standard. What that means, though, is that you have to be willing to say that anyone that gets that much of the knowledge correct, you're comfortable in saying they're going to be a good doctor. This is not much different than the USMLE scores when they have a set point saying that people can be accredited and licensed. And then our honors score is about 90. But everybody in between here is sort of treated identical in terms of their performance. And that's led to some collaborative things in our school. This is just some data that I was compiling when I did this talk. There are 93 schools now in the United States that have a pass-fail or an honors pass-fail system. There are 16 schools, or about 10%, have 4 grades: honors, high pass, pass, and fail. There are 12 schools that have honors, high pass, pass, low pass, and fail, which you could say very reasonably is about the same as A, B, C, D, F, which 28 schools still persist in having. But you can sort of see the predominance of the change is moving towards the honors pass-fail system. The other reason for doing this is that once medical students finish medical school, they're in internships and residencies, and no one gets graded there. Everybody is working together collaboratively, and everybody's trying to do their best to help one another out. So our thoughts, and I think many medical schools' thoughts, is we should start that sooner, the collaborative process. So curriculum reformulation, we tried to get into integration. We wanted to integrate the curriculum, figure out what's important and what's not important, alter our teaching methodologies, try to turn that pyramid and invert it a little bit, make better use of teachers' and students' time, and try to put clinical work into the basic science years. And so the reason for that is that clinical medicine really is integrative. Patients don't come to doctors with physiology or biochemistry problems. There are problems that have those aspects in them, but they're all integrated. Memorizing facts, which is what a lot of students were trying to do, as a main strategy for medical education, is doomed to fail. And what was sort of interesting is in the old system, where everything was graded with multiple choice tests in the first 2 years in classes, the really good memorizers scored really well on those examinations and got really high scores, but they weren't necessarily the best students once you got to the wards and taking care of patients. The USMLE questions that all of our students are working towards trying to pass, they really incorporate this integrative strategy of trying to incorporate organ systems and bodily processes. And when you teach by scientific discipline, it increases the possibility, I've already mentioned, of sort of those esoteric new developments that are exciting for the field but are irrelevant to medical school education. Those things get taught rather than the important core disciplines. So what we did, this is some of the logistics, is that we got all of our course directors together in the same room for multiple hours every week of the year for about 3 years. And these individuals, some of whom had never really sat in the same room with one another, but had sort of known that, oh yeah, he's teaching the next hour after I'm here, were now forced to put on the table all of their lectures and all of their courses. And a couple of really interesting things occurred. First off, these individuals sort of recognized that, oh, well, you're teaching the autonomic nervous system here, and I'm teaching it there, and you're teaching it in your course. In fact, the autonomic nervous system was taught 5 different places in the curriculum by 5 different teachers in different parts of the sense. And they said, well, that doesn't make any sense. Let's only do it once, but let's do it right, and let's do it when it's most proper. And so there was lots of heated discussion on when that should be. But ultimately, it happened in multiple different occasions where this unintended redundancy was being found. And what ended up happening is the amount of time spent to present the information was cut back. It became more efficient in the teacher's time, and they started to craft a curriculum that looked integrated and made a lot of sense. The other thing that they had to do was they had to decide what was going to be relevant for the medical students, rather than the medical students learning all of this stuff and then sort of forgetting that which they didn't need to know later. They used Dr. Hardin's, Dr. Hardin is a medical educator from Dundee in Scotland, and he actually has written a really nice paper talking about integrating curriculum. He has this ladder that he uses as imagery talking about curriculum planning, where from the different stages of one down here being where the curriculum is totally isolated, every subject matter is by itself, up to being totally transdisciplinary, where you have talking by subjects and disciplines, and now there's more integration across the disciplines, to the very top where the student is really taking responsibility for integration. We probably started somewhere down here when we were embarking upon our different efforts, where we really had stuff done pretty much by subjects and disciplines. Sometimes we had things lined up so it made sense, but they weren't integrated. I think when we were done, we're probably somewhere around here. And as we continue to work towards getting to a full transdisciplinary integration, we have to look at the different time and resources it takes to get us there, as well as evaluation and the new sets of tools and goals that we need to do. But this was sort of our roadmap for doing this type of integration. And what we ended up doing was we created horizontal and vertical structures. The horizontal curricular structure was first suggested as 4 themes were developed. What we wanted to do was integrate the subject matter formally identified as individual courses, but we were going to make that horizontal across the entire year. We had a fundamentals of patient care focused on the professional development and behavior. And so let me just show you this. This is our first year, and we had 4 themes. The first was called structure and function, the next homeostasis and regulation, the third molecules and energy, and the fourth the fundamentals of patient care. And within structure and function, if you tried to tease that out, that became our old anatomy, which included gross anatomy, histology, embryology, physiology, and cell biology. It really is the structure and function of living systems. then how do those systems, or how are they regulated? Well, that happens to do with neuroscience, the neurosystem, endocrinology, and to some degree genetics. And then molecules and energy, how do they get the necessary energy to do the processes needed? That's primarily through biochemistry and nutrition. So that's the way that our horizontal basic science curriculum went. With the fundamentals of patient care, we were looking at two themes. First, having to do with the physician and the patient, teaching students how to interview, do physical diagnosis, having awareness about patient diversity, behavioral science, and critical thinking. But we also wanted to incorporate aspects of becoming a physician, making that change from being a student to being a physician. So we wanted to talk about building a life in medicine, about their wellness themselves, about how to develop their own careers, and how to develop professionally as an individual. Overlaying these horizontal curriculum is a vertical curricular structure which was developed primarily around the ways of organ systems. And we had one foundation block that started off, and then we had 6 organ system blocks followed by a final synthesis block. And let me just show you that here. So here's August to December of the first year. We have a foundations block where some of the nomenclature and necessary terminology is introduced. And then we have a multiple musculoskeletal extremities block, a cardiovascular block, a respiratory block, renal and gastrointestinal block, urogenital reproductive block, cognition and control block, and then this synthesis block at the end that I'll talk a little bit more about. What we also wanted to do, though, was make sure that everything that we taught was clinically relevant. And so for each block, the patient had to be the focal point of the block. And what we ended up doing there is introducing the student to a patient with a physician, and we had clinical and basic science topics that were connected to this patient through the entire block. So this is putting it all together. We have the very first session of every block has a video of a patient with a physician. And during that interaction, a whole list of learning goals and objectives are developed that are then taught through the next several weeks of that block. And at the end, the synthesis of those questions that were generated from that very first video are then answered in a way that closes that loop educationally for our students. And so that's the way that we set up our integrated curriculum for the first year. The weekly structure for our students was then, we essentially had morning lectures, but every afternoon, rather than having lectures, we created these small learning groups that we called COM teams. COM stands for College of Medicine. And they were consisting of 9 to 10 students and 2 to 3 faculty preceptors. They met every week. Also in the afternoon, they had laboratories, some simulation centers, some physical diagnosis. And one afternoon, they were given totally off for self-directed study. And here's an example of the schedule. So in the morning, we had lectures, and in the afternoon, we had these different groups. So for instance, Group A on Monday would have small group interviewing skills in their COM team lab. Then on Tuesday, they would go to the anatomy lab. On Wednesday, they would be free for self-directed study. On Thursday, they would go to the simulation center for a cardiology exam. And then on Friday afternoon, all of the students got together in the anatomy lab. And actually, we created some teaching sessions where the students were expected to teach one another in the anatomy lab. And then there were different groups. We ended up having 20 different COM teams. And during that time, those COM teams met each week with their teachers and had the small group learning session rather than the large lectures. One of the innovations that came out of this is the synthesis review block that I want to talk to you about a little bit. This is a teaching exercise that we do that I have not seen done anywhere else. And it's pretty exciting because what we wanted to do was we wanted to get an opportunity for our learners to practice some of the skills that we were hoping they would learn, and to do it without any lectures at all. So this is the final rotation of the year, totally devoid of lectures. And what we tried to create for them was a situation where there would be some team-based learning, some self-directed learning. They were actually going to create an academic poster and were being compelled to make an oral presentation. And then they were going to have peer reviews of their performance. And so this is how it worked. If you remember the summary of the first year, this is the way it was set up. The students were going through their lectures and going through their comm team learning until they got to the very end, which is this synthesis block. The synthesis block was designed to be a review of the entire year of learning, everything that they had learned up till this point. What ended up happening in the synthesis block, it was 2 weeks at the very end of the year, and the very first session of the synthesis block had a patient. Now, this patient had to be made up a little bit because this patient had to have problems that encompassed the entire year, essentially. But we ended up having a patient case presentation where the learning goals and objectives for the entire year in large format form were created. And we ended up having 6 domains in which those goals and objectives were comprised. And those 6 domains were in the musculoskeletal block, the cardiovascular respiratory block, the renal GI block, genital urinary reproductive block, cognition block, and then the fundamentals of patient care. So now we have 6 major topic areas from which this patient has problems. And then we ended up subdividing each of those different 6 sections into 3 subdomains. So there were 18 subdomains altogether. Then what we did was we took all of the students and we took them out of their original comm groups and split them into 18 working groups, 1 for each of those subdomains. And we did it in such a way that every comm group, A1 through A5, B1 through B5, C1 through C5, and D1 through D5, had representation in each of those 6 domains. Okay? Now, these working groups worked together for about 3 days, and they met with their listing goals, review goals, and objectives from each of those large domains. They compiled and answered and created explanations for all of those review topics. And then as this working group, they got together and had to create an academic poster. Now, one of the things that was sort of interesting for us is that many students had never done a poster before. And of course, in academics, you're doing posters all the time. So we figured this was a skill that they would be able to learn for us as we went forward. We printed the posters, and then the students themselves had to prepare an oral poster presentation. And each one of them had to describe what they did when they made their poster. Sometimes they had to describe 3 posters because there were 3 subdomains within one of those large domains. And they became peer experts in that particular content area of review. Then the students and the faculty members reassembled in their original comm team learning groups, and every student had an opportunity to present those posters in the subdomain that they helped to create. And they were teaching their colleagues that they had worked with the entire year review on the poster. The presentations, we actually had them peer evaluated for quality, clarity, and content, so the students were evaluating their colleagues in terms of how they did. And this is sort of the complex schedule for the way we did this, but there were 6 simultaneous sessions going on at any one time, and people rotated through the entire day. This is just the afternoon, but it went morning and afternoon. After the scheduled poster day, here's a picture of one of our students presenting to her colleagues the different posters. And here's another picture. And the physician teachers that were the preceptors were also in the room that were monitoring things going on. But none of this happened with any lectures or with very little faculty input. The students were all on their own. After the poster day, for the next week, the posters were left up, the students were studying and reviewing, and then on the day 9, they had the comprehensive exam. that we would give for multiple choice questions that we would normally do at the end of the first year. And then we also, to try to test whether or not we were doing the right thing, we got some questions from the National Board of Medical Examiners for the United States. They have this ability to customize a multiple choice question exam. And so we selected questions from there and to see how the students would do on the standardized exam. And so our results were that the multiple choice scores demonstrated good understanding of course material, and the NBME customized exam correlated with that as well. Some of the skills that we had as far as outcomes was that every one of our first year students had the opportunity to create a poster, and every one of them also had to orally present to their peers. And then the attitudes was that you had to work with your peers in order to be successful in this particular exercise. And these are some of the comments that the students gave us after we did this. I really liked working on the posters, creating Word documents that the rest of our class would come to rely on for their final exam studies. I think everyone stepped up their game, knowing that how well they did their job directly affected their classmates. A couple of other comments. The format of the block was brilliant. Group work and presentations were definitely helpful. The amount of time allocated was also very useful to relearn the material thoroughly. Again, this is a review for the entire year. I thought this block helped to bring everything together from over the year. It helped us reflect on all the material that we have learned. The learning objectives were helpful and eased a lot of stress when it came time to prepare for the final examination. And this particular block was actually published in November of this year in Medical Education. This is just a summary of the year 2. Again, you can see the horizontal structure, abnormal structure and function, pathogens and host defenses, pharmacotherapeutics and nutrition, the different subject matters involved there, and then the fundamentals of patient care, where we have advanced interviewing, physical diagnosis, we talk about introduction to clinical ethics, clinical reasoning, and all of those sorts of things that are carried out horizontally through the year. And then overlaying them are the different organ systems, foundations of human disease, autoimmunity, hypersensitivity, pediatric hematologic and dermatologic diseases, renal cardiopulmonary diseases, neurologic, psychiatric, and endocrine diseases, and metabolic, reproductive, and gastrointestinal diseases. And then at the end of our second year, our medical students, they have a board review for the Step 1 exam. If you remember back, I told you about 2 curricular goals that we talked about, and the reason I'm bringing this back up is that for our third year, because the way that it was set up before was kind of restrictive, we said we wanted to design some flexibility into that. And we also wanted to come up with different ways to promote student achievement and develop self-directed learning. And so, in our old curriculum, we had the standard clerkships of surgery, medicine, psychiatry, and neurology, which were split, and then these 3. And what we did with our new curriculum is we created what were called selectives. The selectives are listed here, and what we ended up doing was shortening each of these rotations by about 2 weeks, with the exception of psychiatry, which we lengthened for 2 weeks, and we totally got rid of neurosciences, which caused some people in neurosciences some grief. But then what we ended up doing is we created these selectives, which were clinical experiences outside of the core. So that meant that our third year students had an opportunity to do work in some of these other fields: dermatology, anesthesiology, radiology, ophthalmology, otolaryngology, pathology, radiation oncology, and orthopedic surgery. And then they could also do subspecialty experiences in the course. So rather than just doing internal medicine, they could do cardiology, for instance, or maternal fetal medicine and obstetrics and gynecology. They could do a rotation on transplant surgery, and so on and so forth. And then we also created a whole bunch of neuroscience offerings that they could select to choose. Now, everybody had to select something, so it wasn't like they had free time, but they now had more options for choosing how they wanted their careers to go. And that was what we changed in the third year. The fourth year, we didn't change very much except for one particular item, and that was we created this rotation called Internship 101. And Internship 101 is another interesting innovation that we're trying to get published. It's an elective in the 4th year that is a capstone type of offering. I don't know if any of you know that term. The capstone reference in United States medical education refers to a rotation in the 4th year where you sort of capture all of these orphan topics that medical students don't necessarily learn in any particular of their courses, but they really need to know before they become interns. Well, what we wanted to do was, rather than creating a capstone topic and put everyone through it, we wanted to promote self-directed learning. And so we created our Internship 101 to be just as if you were going to an academic conference. And you're going to an academic conference in the continuing medical education realm, and there will be different things that you can choose from that you will want to attend. And there will be simultaneous sessions, and there will be workshops, and there will be abstracts, and you will be provided a menu of offerings, and you had to attend so many, in our case, you had to do 30 hours over 2 weeks of different course offerings in order to get credit. Now, the way that we also created the subject matter for this conference is we sent out a proposal, a call for proposals to the faculty members of our school and to the residencies and the program directors, and we said, hey, do you want to submit a workshop to our conference, which is Internship 101? And surprisingly, many of them did this. It was kind of a neat thing because the faculty members now got to say, oh yeah, I'd like to always talk to them about this, so on and so forth. And here's some of the topics that we had in Internship 101. We had Simulation Center talking about interprofessional rounds. ACLS, Advanced Cardiac Life Support, was in there. Improving your clinical teaching skills. Communication and courtroom testimony for people that are worried about malpractice. Wealth accumulation during residency and beyond. In medical school, the money is going out with tuition. Once you become an intern, the money is now coming in. What are you going to do as you worry about finances? Some survival guides. We had specifics, so for those people going into pediatrics, what are the key things you need to know your first day on internship there, and so on and so forth. Disaster preparedness. We actually had some disaster drills, and I'll show you some pictures there. Some specific issues regarding death and dying and humanism in medicine. Billing and coding clinical procedures. This has become a huge topic in American medicine because of the way the reimbursement is set up. Pain management, medical professionalism. Those are just the partial list of some of our topics. And here's some pictures of people in the Simulation Center working with a critically ill patient. There were scenarios that Matt McAvoy, one of our anesthesiology faculty members, had created some scenarios where the patient comes in with certain problems, and then depending upon what you do, the patient either gets better or gets worse, and the students themselves had to figure out what to do there. And here's a task trainer where a person is learning how to put in an IV. We had central lines and other things to practice there. And here's an example of the disaster preparedness training. So we had a situation where I think some sort of contaminated spill occurred, and there were these dummies where the students had to triage people depending upon what the conditions were, and then there were decontamination things, and it gave them an opportunity to practice and to understand what happens in the case of a disaster, which again I understand is an important thing in Japan. So the educational outcomes is where I'll sort of finish with tonight's talk. As any of you are educators know, it's really hard to find concretely and objectively outcomes in education. Some of the reasons is that there are usually no control groups when you do educational interventions. The students that you're dealing with are usually uniformly excellent, so whatever you do, it'll probably be okay. In fact, my program director in residency said sort of in a self-deprecating way that they didn't really do anything to teach anybody. They just took smart people and aged them. They allowed them to get old. And so when you're dealing with really smart and motivated medical students, most things are going to be okay. Also, most of the interventions that you do in medical education, you don't see the effects of them for years, if not decades, because it takes so long for the cycle to go through. There's multiple confounding variables. And anything that you're doing in teaching learning is dynamic. So whether you can really point to the educational intervention or innovation that you made as the cause or the effect is really prone to some problems. So some of the traditional measurements that have been used and that we tended to use were no harm. That is, if you look at the performance of students before and then after the curriculum changes, and if things didn't get worse, then you can sort of assume that things were okay. You look at student satisfaction, of course, happiness scales, and teacher satisfaction, which I think in some instances is probably underestimated, but still is very important. When we talk about that for us, the students were much more satisfied with the change in the way the grading system was, the way that they started collaborating with their colleagues, as I mentioned in some of those quotes. And interestingly enough, the teachers, many of those teachers that were in that room doing the really hard work over the course of 2 or 3 years, they found rejuvenation in their teaching. They really got excited about what they were doing rather than putting together the same course that they had done for 10 or 20 or 30 years. Now they were really working with their colleagues and they were trying to be exciting and innovation and to be integrated with other people really made them happy. It also was nice to see that they actually spent less time in some respects teaching because the efficiencies that were gained by getting rid of the redundancy and making sure that what was being taught at the proper time really helped everybody in the long run. It actually helped the department chairs because they didn't have to pay as much for teaching time. There was less time and still covered the same amount of information. Here's some of the no harm data that we have. These are the USMLE Step 1 and Step 2 knowledge scores. And you can see the MUSC students are about average with the United States, maybe a little bit lower. But in general, there really isn't very much change from when we made the change here in 2009. The student satisfaction. Students in medical school are still competitive. They probably always will be. But they're much more inclined to help colleagues. And sort of the whole idea about the new curriculum encouraging cooperation. There are now study groups, there's an expectation of peer teaching, more team-based learning is going on, and more peer evaluation is going on. And I don't know how much credence to put into this, but the U.S. News and World Report, which is this magazine that ranks things in the United States, said that MUSC in 2012 was one of the 10 most popular medical schools to go to for students, possibly because some of this, but I won't claim that in any realistic fashion. Match results, so where do our students go when they are done? So this is a graphic looking at percentage of our students matching at what would be considered top programs, and you could probably debate what are the top programs, but many of those, Harvard, Yale, Stanford, Duke, those kind of places are listed in there. And you can sort of see that at the time of the curriculum change, there really hasn't been very much change. That's been pretty steady as well. So in summary, curriculum and culture change benefits from the established underlying philosophy. That is, I think you have to sort of think about where you see the institution going and what you'd like to achieve by making those changes. To be creative and to have leadership support from above was critical for me in my role with the dean, and then hard work and dedication. Most of the work was done by those faculty and those course directors in that room. I just sort of put them in there and let them go to work, but they had to do all the work from below. And the other thing is, when I say borrow liberally from others, when we were trying to come up with the structure of our curriculum, I looked on the internet and got ideas from UCLA and from Case Western Reserve and from Colorado and from many of those other schools that are way ahead of us in terms of integrating the curriculum, and asked and borrowed very liberally from their ideas, and I think our curriculum was better because of it. So I thank you for listening to me. I hope that this journey through our curriculum, our change and our reform was useful for you. This is a picture from our website, and thanks very much.